awareness program to serve healthcare workers, patients, and their caregivers. Today, we have the renowned gastroenterologist from Chennai, Dr. UVU Vamsidhar Reddy, sir. He needs no introduction. However, I would fail my duty if I don't mention that. Dr. UVU Vamsidhar Reddy, sir, is a leading gastro in Chennai, providing comprehensive and compassionate care to many patients for various gastrointestinal and liver conditions. He has experience building a clinical skill set that allows him to deliver the patient-centric care. He is currently associated with Apollo Hospital at Chennai as a senior consultant. Sir, we salute your dedication to spreading awareness related to liver health. So now I invite Dr. UVU Vamsidhar Reddy, sir, to enlighten us on topic the combating fatty liver actionable insights. Sir, over to you.
Good evening, one and all. I thank you for inviting me for this session, and I am privileged to share my knowledge on fatty liver, and which is a very common problem which is occurring now. And my warm greetings from Apollo Hospitals. Currently, I am working as a consultant hepatology and liver transplant physicians in Apollo Hospital, Chennai. So my focus on the talk will be on combating the fatty liver and actionable insights. So I'll be doing my next 20 to 25 minutes. I'll be doing my brief session on the above topic. Yeah. So first you have to know your liver. So liver is the second largest organ of the human body, weighing around 1500 grams, which is located in the right hand portion of the abdominal cavity. Uh, one minute. So and which is this which is you can see that now representative picture also. It is a brown color and has soft consistency, and which is a highly vascular organ, and it has a unique blood supply that is called dual blood supply. It having the blood supply of both hepatic artery and portal vein. Hepatic artery brings the oxygenated blood, which is represented by the red color, from the to the liver from the heart, and it is a portal vein which is represented in the blue color, which will bring absorbed nutrients from the intestine. So coming to functions of the liver, and liver is called a powerhouse of the body, which almost consists of 500 more than 500 functions of the what the body functions, and the main functions will be is a detoxifying function. Whatever we eat, whatever drugs we take, all the things will be metabolized in the liver, and then it will remove the potentially toxic byproducts. And the second will be it is helpful in the production of the storage of the vitamins, and also it helpful for the metabolism of the metabolism, and also helping in the production of the energy. And it also helps in providing the immunity, as it can fight with the infections by removing the bacteria from the blood. And also it produces substances, clotting factors, which can regulate the blood clotting. And it also helpful in the storage of vitamin A, D, and K, and also helpful in the digestion of the fat. Coming to burden of liver disease, so in India, it is a chronic liver disease is a public health priority in India. So recently, the Minister of Family and Health Welfare has included the liver disease, the only liver disease which is included in this non-communicable disease in the Minister of Health and Welfare is fatty liver disease. And thanks to the government of India to recognize the burden of this fatty liver, and also including in the non-communicable diseases. So it contributes about to 18.3 of the 2 million global liver disease. Out of the all the global liver disease, almost consist of 20% of the liver disease is contributed by the fatty liver, and also when the uh, mortality of 22 million people which who are dying due to uh, liver problem. So out of them, around 20% will be due to the fatty liver disease. And if you see, there are the numbers also increasing as the year grows. The numbers also increasing. The if you see in the by 2016, the cirrhosis is around 199 people, 199 million people that's are there. And fatty liver and alcohol liver disease are emerging as the important cause of this cirrhosis in the country, paralleling the changes in the lifestyle, and also social customs. So, however, mainly is the non-alcoholic fatty liver disease and alcoholic liver disease are the emerging causes. But however, it's still the hepatitis B and C is remained as a major chronic liver disease and the liver cancer. Coming to prevalence of fatty liver disease, if you see there is a, if you see the representative figure, out of four people, if you do an ultrasound or liver function test, so we can able to diagnose, and out of four there will be one out of four people will have fatty liver disease regardless of the weight. And if you see the among the diabetics is, out of six people, out of 10 people, we have 6% of diabetics will have fatty liver disease. Out of 10 fatty liver disease, 9 people will of severe people, obese people will have fatty liver disease. The male gender is has been regarded as a risk factor for the progression of NASH and the fibrosis. And you know that is a fatty liver is not a single disease; it's a spectrum of liver disease. It starts from normal liver, fatty liver disease, and also hepatitis, and then fibrosis, and then come into cirrhosis. So if you see the spectrum of normal liver disease, we can divide into three things: acute hepatitis, chronic hepatitis, and cirrhosis. Acute hepatitis is mainly due to the common infections, hepatitis A and hepatitis C, or some homeopathic, allopathic medicines, or even alcohol can cause acute hepatitis. Chronic can be mainly due to fatty liver disease or alcohol liver disease or hepatitis B and C or any other autoimmune conditions in the females. And finally will be the cirrhosis, which is an irreversible stage. At this thing, if this same thing can progress, then it can uh, progress to acute on chronic liver failure and liver cancer also. So if the patient develops cirrhosis, these are the four common symptoms the patient can arise. One is a varix. This is the blue color thing which you are seeing is the veins which have been enlarged in the esophagus. So these veins can burst out and then can cause a upper GI bleed. And this is abdominal distension, which is called ascites. And the encephalopathy, that means that the patient will have ultrasensorium. And the final irreversible stage is called liver cancer, which may further lead to death or maybe finally leading to liver transplantation. So fatty liver is an emerging epidemic. So as the mankind evolution goes, if you see the primitive figure, so we are also from the normal lifestyle, we are changing into sedentary lifestyle, using of laptops, using of computers, gluing to the TV screens. So all these things and all the beverages, both hot and cold, all these things will cause the fatty liver. And there was a newer nomenclature which has been published recently in the recent after 2020. So this is called because of there was some discrepancies in the nomenclature of non-alcoholic fatty liver disease. So it has been new nomenclature has been proposed. That means the hepatic status in adults, which if anything which we find by either imaging techniques or blood biomarkers, or if you do biopsy for these patients. So if any patient will have obesity, uh, then we can able to directly call as a metabolic dysfunction associated fatty liver disease, as most of the patient will have metabolic syndrome. And the second one is if the patient have a normal weight, lean or normal weight, that means BMI is less than 25, that person also can develop fatty liver disease. And the patients of type 2 diabetes mellitus, if the patients already have, and we can able to call them directly as a metabolic dysfunction associated fatty liver disease. The patient has a normal weight, then at least this out of the seven parameters, so at least two metabolic risk abnormalities should be there, like waist circumference more than 102 by 88 in Caucasian women, or 90 by 80 centimeters in Asian women, blood pressure more than 130 by 85, and plasma triglycerides more than 150, HDL cholesterol less than 40, or in males, and less than 15 females, and the patient having a pre-diabetes levels, or HOMA IR score more than 2.5, or the C-reactive protein more than 2. Out of this, any two metabolic risk factors, we can able to define them as a metabolic dysfunction associated fatty liver, even though patient is having a normal weight. And after that, there was a reclassification has been done in a. They have groups everything as a steatotic liver disease if they found through any ultrasound. And out of them, the one parameter is called metabolic dysfunction. This is due to any metabolic syndrome what is causing. The second is called this is a combined of alcohol and also metabolic associated dysfunction. So this is called meta ALD. And one is called it is when the alcohol itself will cause can steatotic liver disease, is called ALD. And any specific etiology like hepatitis B, hepatitis C, or drug-induced liver injury, so that can cause if it's steatotic liver disease, that is called a specific etiology, CLD. And the final thing is cryptogenic, we will not find the cause. And the final thing is cryptogenic, we will not find the cause. So what we have to understand about fatty liver, this is representative diagram, which is, should be in a brown color, and very soft resilience should be there. But if you see this, there are spots of a white yellowish color will be there, so that represents the fat. So when we call as a fatty liver is if the liver cells are called hepatocytes. The hepatocytes, if more than 5% has been affected by fat, it is called a fatty liver disease. That can be caused by alcohol or maybe non-alcohol. If it is not by alcohol as a risk factor, then it is called non-alcoholic fatty liver disease, after ruling out hepatitis B and C and other factors. So if and as I told, it is a spectrum, it is not a single disease. This is now, it is called non-alcoholic fatty liver disease. If the patient is not getting treatment with that, and if it progresses, then it's called NASH. That means that there is some inflammation occurring within the liver. So NAFLD, there's only the fat is sitting inside the cells, but nothing has happened to the body. So, but if he or she progress to NASH, that means a non-alcoholic steatohepatitis. That means that the liver cells are actually getting inflamed, and there will be abnormalities in the liver function test when we do the blood test. So that is called NASH. If the same thing progresses, then it can cause fibrosis. Fibrosis means it will develop a scar formation, or the softness of the liver will be reduced. That is called fibrosis. If the same progresses for the next 4 to 5 years, then the patient will develop a irreversible stage called the liver cirrhosis. So, being overweight and obese, having type 2 diabetes or high cholesterol associated with increased risk of non-alcoholic fatty liver disease. So, this already I have explained. So, spectrum of fatty liver, whatever I told in the last slide, the healthy liver, that means the fat is less than in 5% of the hepatocytes. In that, if the patient develop a fatty liver disease, it is that means that more than 5% of hepatocytes having the fat. In that 12 to 30, 40% of people, they develop into NASH. That means they may have inflammation. If we do an biopsy, they will have ballooning, fibrosis, and steatosis. In that, if we leave without any treatment, they will progress into 15 to 25% can progress into liver cirrhosis, which is the irreversible stage. And in that, 7% can develop liver cancer, which will finally lead to liver transplant or death. If you make it into numbers, out of India, like around 130, 140 crores of people are there. So in that, 45 crores will have NAFLD liver. In that, 14 crores people will have NASH, and 3 crore having a cirrhosis due to fatty liver, and 21 lakhs as having a hepatocellular carcinoma due to fatty liver disease. So it's a huge numbers actually occurring, which is and it's called a silent epidemic. So because that's why every person, not every person, at least we cannot recommend every person to do an ultrasound, but at least who are having the metabolic parameters like high BP, high sugars, or high cholesterol, or overweight, these patients has to be checked for the fatty liver, and we have to take treatment according to it. And if the patients do a master health checkup, then we have to, if they found out to have a fatty liver disease, we have to do the management according to stage of the fatty liver. So if we do this is the histology what I am explaining. So this white color thing is called the fat within the liver cells, and these are these blue color cells. Blue color things is called inflammation. That means it is infiltrated by neutrophils, and the liver cells, if they develop fibrosis. So if you can see this blue color things between the cells is called septae, which is thickened, and it is called the fibrosis stage. And this is representative diagram of the liver. And if the patient develops cirrhosis, so it is a final stage. This is the fatty liver stage, and this is the cirrhosis state of hepatitis. This is the irreversible stage, which is called cirrhosis. You can see the liver. There is nodule formations, and liver is not looking healthy compared to the normal liver. So fatty liver is not a single it per se. It is pertain to the only liver. It has been a multi-system disease. It can cause a high cholesterol, high BP, and it can females. It can cause polycystic ovaries, and diabetes and the liver, fatty liver. It's like reversible. I mean, it's like a symbiotic relation. If a patient have diabetes, then they have a fatty liver. The patient have fatty liver, they can also cause some increase in the sugar levels. And patient can have kidney disease, heart disease, and who are obese, they can have sleep apnea also. So if you see the patients of fatty liver and liver transplant in 2005, the data shows 13% of the whole liver transplant is constituted by the fatty liver disease. But in 2020, due to the increasing Western lifestyle, and also increasing sedentary lifestyle, increasing the quantity of the diet what we have taking, all these things has amounted to increase in the fatty liver numbers, and the transplants also automatically will increase. So it has been 39% increase is there. So that means that almost three times it has been increased within the span of 15 to 20 years. So, who are the people at risk of fatty liver? So, I already told who are having diabetes, obesity, hypertension, high cholesterol, hypothyroidism. There will be some genetic predisposition, PNPLA3 gene, all these things. But for they are used for only research purposes. But currently, they are not in the clinical arena. And physical inactivity. All these things are risk factors for fatty liver. So, these are the patients who has to be screened for the fatty liver. So, and I told diabetes and fatty liver inter bidirectional. So, if the patient have diabetes, they will develop fatty liver. If the patient have fatty liver, they can develop diabetes. So, what are the symptoms? So, generally, 80% of the patient will not have any symptoms. These are generally found. We'll be finding them when we do a mastocytic checkup, or we'll do an ultrasound for some other reason. We'll find a fatty liver. So, generally, the way if the in the 20%, the main thing will be there will be some increased fatigue, some gastric symptoms will be there, and some digestion abnormalities, or some patients who have developed already cirrhosis, they'll have confusion, they'll have swelling of the lower limbs, there'll be some, if the patient develop liver cancer, they'll have unexplained weight loss, and some patients will develop jaundice, and some patients can develop upper GI bleed, which can be due to the rupture of the esophageal varices. So the most common symptom which is found is the vague fatigue, right abdominal pain. Right abdominal pain because as the fat get accumulated in the liver gets uh, enlarged. So with around the cap, there will be a capsule called Glisson's capsule, which will be also stretched out. So that is the reason for the right abdominal pain. And some patients have some nausea and vomiting can be there. So how to diagnose the fatty liver disease? So it's as it is a silent killer. We have to be proactive in diagnosing the fatty liver disease. So that can be done by blood test, any imaging techniques like ultrasound, fibroscan, or MRPDFF, and a liver biopsy for the pathology, or maybe we can do the higher investigations for research role like MRPDFF. So the simple test everyone can do in all the blood tests is liver function test. So in that we have to see the SGOT, SGPT. We have to rule out hepatitis B, hepatitis C, alcohol, and other autoimmune conditions, and then we can put all the blame on fatty liver disease. The patient have metabolic dysfunction. So there is no designated ALT cutoff, but almost 80% of the patients will have the normal ALT, even though patient have fatty liver. That means that they are in that fatty liver stage. I mean, so, non-alcoholic fatty liver disease. If they have the AST ALT abnormality, then the patient will have the non-alcoholic steatohepatitis. So, what are the non-invasive markers like uh, non-invasive scores for fibrosis? That's what like it's called FIB4 score, NAFL score, and recent there is called Agili score has been included 3 and 4. So all these scores are important because for the diagnosing the fibrosis in the fatty liver stage, fatty liver disease, and also helpful in the prognostication of the patients who are having high fibrosis. That means if it is more than fibrosis more than or equal to 2. So FIB4 stage we have a simple components like age, AST, ALT, and platelet count. This should be this calculation of FIB4 score should be developed in all primary healthcare centers. So if this is more than 3.25, that means the patient had fibrosis. If it's more than 1.5, that means the patient, if less than 1.5, that means is normal. If anything between this, the more than 1.5, so it is better, always better to more than 3.25, it is always better to refer to the higher centers for further management. And the same thing, NAFL fibro score, it consists of all the same parameters of FIB4. Extra thing will be having BMI, fasting glucose, and albumin. So why we will do is it is for diagnosing and also for prognostication of the fatty liver disease. And all the and you pretty well know that everybody fatty liver disease can be diagnosed by, mainly they'll come to us with the diagnosis of fatty liver disease by doing an ultrasound. So because it is easily available, economical, and mostly the like accidental diagnosis will be there. So from the other department they'll be referring to hepatology department. So but only disadvantage with this is it only detects with the fatty liver disease more than 25%. So as I told, it's less more than 5%. It is called fatty liver, but 5 to 25% is a gray area which cannot be detected by ultrasound. And if you see, this is the cirrhotic liver. If you see, this is normal liver and cirrhotic liver. If you see, this is not healthy. They have irregular borders. And this is a fatty liver. If you see, this is white in almost. It is like homo. It is diffusely increased bright echogenicity is there. That means that the fat is getting accumulated. This is normal ultrasound, and this is the fatty liver fatty liver ultrasound, and this is the ultrasound of the cirrhotic liver. So next comes the newer techniques of non-invasive techniques is fibroscan. So it works on the principle of transient elastography. What we do is we'll put a probe. There will be two probes, M probe and this called XL probe. XL probe we'll use for the obese people. M probe we'll use for the medium-sized people. So XL probe we'll keep and then we'll put on the right hypochondrium, and then we'll do the 10 vibrating 10 vibrations will be inducing into the patient through the probe, and these vibrations can pass to the liver and then they will be reflecting back. Based on that we'll be calculating the liver stiffness measurement and also control attenuation parameter. Control attenuation parameter it indicates the degree of fatty liver based on the S1, S2, S3 will be more than 240 it is called 240 to 260 it is called S1, and 260 to 300 is called S2, more than 300 is called S3. And the liver stiffness also same thing. It is like less than 8 it should be normal, and more than 8 to 10 is F2, and more than 10 to 12 it is called F3, and more than 13 it is called F4 fibrosis or cirrhosis. So if you do see this, this is the what we got. We'll get the report. This is 198. That means there is no fatty liver. Nothing is there. And 5.2. That means it's a completely normal liver. As the that slope of this curve is coming to the left side, the value of the also will be increasing. That means the liver is becoming more and more stiff. The advantage of fibroscan is it is more than 10% of fat. Also, it will be diagnosing, and it can differentiate with the fibrosis and also fat content, and is easily to operate. And even a technician also can do it. But only thing in obese patients, it will be misinterpreted and slightly costlier than the ultrasound. Coming to MRPDFF, so the MRPDFF, this here this is the gold standard one other than the liver biopsy. So what we do is we'll introduce a software in the MRI. So it will estimate the overall liver, and it will estimate the fat content in the overall liver through the software, and so that we'll get the overall idea what is happening in the whole liver. So it is a gold standard for detecting a fat content. It can measure more than fat, more than 1% also. Widely, it is definitely used for all liver donor patients, for liver transplant patients, but general population will not use. Only it is useful for the research purposes. But but it is a costly it is the other disadvantage, it is also costly. So other thing is the gold standard method is a liver biopsy, but it's an invasive procedure. This generally will only do to the patients when they come to the clinic. They have a concomitant other liver diseases also. To rule out other liver diseases, the patient have hepatitis B and also fatty and also having metabolic dysfunction. So then we have a dilemma whether this is due to hepatitis B or due to fatty liver. That patients alone will do the liver biopsy. It is not for all the patients, or some patients will be including for the research purposes, so that by that time we can do liver biopsy. So the disadvantages are painful. It is the disadvantage of the liver biopsy that it is painful procedure. Some risk of bleeding will be there, and we'll only sample in some part of the liver. Maybe that part of the liver, maybe there is no fatty liver can be there, other part can be having a fatty liver. So now comes the prevention. So the main thing is maintain the ideal body weight. So what is ideal body weight? Is the height minus 100 centimeters is the ideal body weight. What is healthy eating? So I'll come to the next slide. But healthy eating is so reducing the carbohydrates, increasing the protein intake according to the body weight, and maintaining the Mediterranean diet. So I'll come into the next slides. What is it that? And no alcohol for all the patients who have been diagnosed with fatty liver disease or any liver problem per se. But if, who are having liver functions are normal, and or who are having there's no fatty liver, so they can take alcohol within safe limits. They should know what is safe limit also. That means 2 drinks per day in a in a male, or more, or it is like 1 drink in a female. So 1 drink is almost equal to, if 30 ml of whiskey is equal to 1 drink. So regular exercises, and regular exercise, there will be the both resistant exercises and aerobic exercises that I'll come into next slides. Any exercise is useful. There's no superiority found between the both things. So any exercises at least 40 minutes to 60 minutes per day is an helpful measure for the fatty liver disease. And annual health screening, because most of the patients will diagnose to have fatty liver disease by the screening methods only. For all the metabolic dysfunction who are having like high BP, high cholesterol, high BP, and high sugars, all these patients are definitely mandatory to do screening for fatty liver disease. All other patients generally they can do an yearly master health checkups. Then they can, if they found to have a fatty liver, they can come to the hepatologist or gastroenterologist. So what is first of going to a healthy diet? What is good for the liver is cruciferous vegetable like broccoli, cauliflower, beetroot, leafy green vegetables, all the antioxidant foods like citrus fruits, eggs, fish, and garlic and coffee. Coffee is like it's like a black coffee. It is not the protein coffee with milk and sugar, and which is not good for the liver is sugar. 3S will tell sugar, salt, and saturated fat. Sugars like aerated drinks, soda, cola, baked items like sodium bicarbonate will so the soda, baking soda will be there, and bread, biscuits which are and which will have a baking soda for which will be used for the making, and French fries, burgers, and pizza, and is junk food and red meat and excess salt. All these things are bad for the bad diet for the liver. And who requires the treatment for the fatty liver? Treatment should be indicated in three conditions. One is who is having already NASH or early stage of NASH with the risk of fibrosis progression. That means high ALT levels, diabetes, age, and more than 50 years or metabolic syndrome. Or active NASH with if you do a biopsy for the patient, if there is some necro-inflammatory activity is there, so we have to treat the patients. So if we treat the patient, the NASH patients will not further progress to fatty fibrosis or cirrhosis or HCC. So treatment of NAFL liver, this is a nutshell. So diet, exercise, both aerobic and resistant exercise, lifestyle modification, no alcohol, no cigarette smoking, and increasing your exercises, and decreasing your sedentary lifestyle, and the new medications which is coming recently. So these are the plan for the management of the fatty liver disease. So what diet to be followed? So we have to reduce. Normally, we eat around 2,000 to 2,200 calories according to the weight. So we have to reduce by 500 kilocalories per day, and we have to use balanced Indian diet is good, and high protein should be there, and avoid refrying of the oil, and cut your sugars from your diet from as soon uh, as possible. And this is the diet chart what we tell for fatty liver disease. The if you see the base of the pyramid will have a base of a triangular pyramid will have whole grains, bread, pasta, rice, and potatoes, legumes, and vegetables will be there. As the pyramid goes up, so we have to reduce fruits and nuts, and that means it like 2 to 3 servings per day, and olive oil 2 to servings per day, and milk also we can give 2 to 3 servings per day. As if you come to the fish and seafood, at least 2 to 4 servings per week it should be there, and eggs also same thing, and sweets 1 to 2 servings. If your fatty liver is there, it's better always to better to avoid sweets. And the red meat maybe in monthly. Red meat generally we'll tell that reduce as much as possible. If it is using also, it has to be in a monthly 1 serving to 4 servings can be there. So coffee and fatty liver, recent publications has told 2 cups of a coffee decrease the risk of dying from chronic liver disease by 30%. But this coffee is without milk and without sugar. It's like a black coffee. So exercise regularly. There I told already aerobic exercise. It reduces the liver fat, maintain the healthy weight, it improves the cardiovascular functioning. And the resistant exercise reduce the liver inflammation, increase the glucose absorption, and improves the insulin sensitivity, and improves the metabolic parameters. So any exercise you can do, but it should be for 150 minutes per a week, or we generally tell that is 40 minutes per day. Maybe week half we can take. And 10,000 steps a day, and through with this we can easily come to know all the calorie diet what we are eating, all these things we can get to know by the apps in the mobile phones, so that we should be vigilant in doing all this exercise and also having the healthy diet, and take a small breaks while sitting for the prolonged periods, and use states whenever possible. And this I told, if the weight loss is more than 3%, if the more than the excess of the ideal body weight, if you reduce 3%, more than 3%, then the liver steatosis will decrease 35 to 100%. If the weight loss is more than 5%, then the inflammation, the whatever I told in the biopsy, if you see the inflammation, that will reduce by 40 to 100%. And more than 7%, 64 to 90%, even the NASH completely resolves. And if even the patient in fibrosis stage also, if that can be reversible if it's more than 10% weight loss is there. So summary of the management of liver disease: limit the intake of fatty liver and saturated fats and trans fat, eat a balanced diet, limit the consumption of refined carbohydrates, maintain a healthy weight, take medication as prescribed, limit alcohol, avoid alcohol, exercise regularly, and quit smoking. So only you can change your life, no one can do it for you. So this is the nutshell of the slide for the fatty liver: what to be taken, what diet, exercise, and what to be done. So what fits your busy schedule? Exercising 1 hour a day or being dead 24 hours a day? That we have to decide. And coming to medication part, generally the newer medications, what has been come is saroglitazar and vitamin E. Initially there was only vitamin E, metformin, pioglitazone was there, and vitamin E has been found to be in all the major the major studies. It has found to that it will also help in the reducing the fat, and also it is helpful for the progression of prevent the progression of the disease, and also helpful in the liver cirrhosis with the, due to fatty liver. It prevents the decompensation also. So that is recommended in all societies. Coming to pioglitazone, we can use it, but the chance of weight gain will be there. And coming to metformin, that has been discarded now. And the newer molecules which has been coming in the pipeline, the main thing which has been endorsed in India is from the DGCA, and also now in the recent EASL 2024 also they have endorsed in their publication, like saroglitazone, giving 4 mg daily for at least 52 weeks. Generally, we give for 1 to 2 years. So it is helpful in reducing the AST/ALT. It also helpful in reducing the fibrosis. It's also helpful in the reducing the inflammation which is happening within the histology of the liver. So and that is one. And these are all the this not it should not be this the medication should not be substitutes to the management of the fatty liver. The main thing should be weight loss. So the weight loss can be by the diet or by the exercise. The after that the secondary things can be by the medications that will help you in accentuating the reducing the fatty liver. Like in my practice, I generally use a vitamin E and also saroglitazar in as a combination. As the studies also says, both combination will be helpful for the uh, reducing the management of the fatty liver disease. I generally use, if the patient is having a AST ALT normal, I generally prefer to give only vitamin E. If his AST ALT or abnormality is there and patient have high grades of fibrosis, then I'll straight away go to saroglitazar and also combine with vitamin E, and for a span of 9 months to 12 months. And I'll again follow with the fibro scan and also liver function test, and then again I change according to the values what we get after 1 year. So what fits your busy schedule is better is exercising 1 hour per day or being dead for 24/7 is the we have to decide what is best for us. So thank you.
Thank you, sir, for this wonderful talk. Definitely, this has enlightened us. So now we will take the question from our audience with your permission.
Yeah.
So there is a one question is commonly asked by the audience is that when we have to consult the specialist for this fatty liver
Yeah.
disease.
Yeah, see, generally, see, fatty liver disease will be diagnosed by from the coming to MBBS to MBBS, MD people or the specialists. Everyone will diagnose, or we so it is not required for every fatty liver has to come to the hepatologist or gastroenterologist. See, what we tell to the people is you can manage in the own city, because a fibroscan all these things will not be available in the normal cities. So what we tell to the patients also, if they come from far away place, we tell that. So to do, if any patient with diagnosed with fatty liver, we tell that so you have to calculate a simple score. So what I told, FIB4 score, or if you have the facility to have a fibroscan, if the fibroscan showing more than F2 or equal to more than or equal to F2 fibrosis, or patient having a liver function test abnormality, or patient will having a this FIB4 score is more than 3.25, then we can these patients alone is required to for the specialist treatment. All other patients, as everybody know by this time, because as fatty liver is being increasing, so everybody by the weight loss and also the medications what they even the physicians are using, MD people are using. So I think fatty liver can be manageable at that stage also. But if these three things are there, I prefer to shift the patients to specialists. Or the fourth thing is did not mention, if the patient already develops cirrhosis, that patient definitely has to be shifted to specialist for further management.
Sir, for that, what are the risk factor and causes of for this fatty liver disease? So might
I already mentioned.
most of the
Yeah, I already mentioned. So the risk factor. See, that's what I told. See, if If you are very healthy and everything is normal, so there's no need to go to the to get to do the blood test, to do the LFT. If a 30 year 40 year young man, if nothing is happening, if he's a pure means he's not an alcoholic, if he's not having a diabetes, he's not having hypertension, he's not having a high cholesterol levels or high triglyceride levels, there is no need to go to a for screening of the fatty liver. If this patient is having this then obesity, hypertension, diabetes, polycystic ovaries, hypothyroidism, these are the 5 to 6 risk factors, then the patient has to go for the liver screening also, because generally it will be missed. Generally everybody will do all the renal function tests, like heart test, all this thing, but liver is as it is in the it will be like it will be like a bystander. So we have to just see the what is happening to liver also in these patients of metabolic dysfunction. Otherwise metabolic dysfunction, and also the patient who am having already cirrhosis, they will have a symptoms of abdominal distension, pedal edema, jaundice. All these patients has to check for the liver to know any fatty liver is there or not, or patient having cirrhosis or not. Not every patient is required to have to get screening for the fatty liver.
Okay, sir. Thank you, sir, for this your information and I'm definitely sure all the audience have definitely understood what you said in your presentation. So, sir, on behalf of Nest 24 by 7, I thank you for this lively and informative talk. As you have been emphasizing the awareness of liver health and disease, it is equally important for people affected by fatty liver to regularly visit doctors and continue medication. With careful observation and precaution, it is possible to obtain the control of the disease. I would also like to thank our audience for their active participation and the patience in making this event successful. Stay connected with Nest 24 by 7 on Facebook and take care of yourself and your family member. Thank you, sir. Thank you very much.
Thank you. Thank you very much.